As I got another rhyme, another rhythm for y'all to listen. I'm never quitting on my mission, I'ma roll with what I'm giving. Got some ambition, this new edition, filling positions. Looking at the void in myself and feeling what's missing. Better watch the way you going, better go in the right direction. In the moment you stressing, but you gon' be counting blessings. And I know that for certain, keep on working, open curtains. Haters swerving, cause they ain't ready for your final version. Ooh. I'm never gonna give up, fall down, I just gotta get up, yeah.
You're listening to the Tom Ficklin Show on WNHH-LP 103.5 FM, your home for community radio.
Good morning, everyone. And that melodious voice you heard is Harry from our station manager, WNHH 103.5 FM. And Harry was kind enough, and I don't think he minds us sharing that he's recovering from COVID. And I share that to say, just, be alert, folks. We are still up in the midst of things. So just be alert, be cognizant and be proactive. I mean, today's show actually is about being cognizant and proactive and alert. We're going to talk with Dr. Cece Calhoun and Reverend Dr. Leroy Perry and Reverend Elvin Clayton are joining us. And Dr. Calhoun is the Assistant Professor of Medicine, Hematology, Medical Director of Sickle Cell Program at Yale University Medical School. And I mentioned Dr. Calhoun in terms of promotion for this show. I shared it with a lot of people that this show is not about life and death, but it's definitely about enhanced life. It's definitely about the quality of life. So I didn't not to shock people. And there's so much we can talk about on the air and in the social media, et cetera, about the crisis that's going on in the world, whether there's nuclear bombs being shot or considered to be launched. But while we're here on the planet and able to breathe and share and look at each other in the face, I'm just so blessed to do this show where we're focusing on life issues. What does it mean to be healthy and thrive, not just to survive, but thrive? And you've been involved, Dr. Calhoun, with thriving issues, with survival issues, with prospering issues in terms of health and sickle cell in particular, and the challenges of the sickle cell disease. Just before Dr. Calhoun, that I plunge in, some of the staff was kind enough to share with me statistics about who has the trait and who has. And when I saw these statistics, that's one thing. But when I do a show, 2 or 3 days before I do a show, I walk around and talk to people and say, well, I'm going to do this topic. And at least 50 to 60% of the people that said we're going to do a show on sickle cell said they know of someone or someone has the trait. So I think these statistics are a little bit underreported in terms of the prevalence, but it doesn't matter. Even if just one person has sickle cell, that's one person too many. And in terms of the discovery and the science and the health research that you're involved with, it's just such a pleasure to have you here for the next 45 to 50 minutes. This is September is National Sickle Cell Awareness Month, but again, you dedicated your life 24/7, 365 to sickle cell being a preoccupation, your every breathing and waking moment. So it's a pleasure to have you here. But just tell, and again, I just wanted to let people know also that you were kind enough to be on this show previously, and we promoted but you've received a promotion since then, I'm told. So that's a good thing. That's a good thing. Yeah. And promoted to the position of medical director for the Sickle Cell Program. Medical director for the Sickle Cell Program. What does that mean? I mean, I'm assuming you're getting a little more money, but I mean, you can give it to Dr. Perry or Dr. Clayton or your philanthropy. But share with us the good news about your new position as the medical director for the Sickle Cell Program.
Well, firstly, thank you for having me back, and thanking you for having me back with Reverend Dr. Clayton and Perry. They're my best crew to talk to and with, so I'm thankful to be here. But most importantly, thank you for giving a platform for awareness for sickle cell. And truly, the principle of thriving is something that's important to me in the work I do every day, in my own research and my clinical practice. And so, just how we care for one another as Black people. And I also totally agree with you about those statistics. We often quote a study that was published in 2017. That's kind of like a landmark study that we use in the literature talking about background. But we know that there's probably increased incidence and increased prevalence as we think about new treatments and therapies. So for me, I did get a promotion, very exciting, very fun year. But for me, the biggest change, I think, is the ability to have impact and influence. And a priority of mine is engaging our patients and our whole community, those with and without sickle cell, and wrapping around the ones we love who have trait or who have sickle cell disease. I think there is so much we do in the medical space, but we know that people live full lives outside of when they're at their appointments or getting their treatments. And there's a whole other side of sickle cell disease awareness, life experience that you really only get from patients and community, that I really hope to really partner with, learn from, just as, Reverends Clayton and Perry have done in any other scientific settings. I really want to do that as medical director with our sickle cell community and amplify their voice. So yes, more influence and more ability to make change. That's kind of how I view it. And be able to do some redesigning and building in our program here.
I want to, I appreciate your sharing that. I want to ask how many people you see, but even that's not a fair question, because even if you see one person, you're seeing that person's network, you're seeing their grandma, their people that are around them that you don't. So but just generally, how's the flow coming in terms of number of folks that you've had a chance to bless and to share your presence with?
You are so insightful. I think like sickle cell impacts not just the person, but their whole community and support network, like many things. So here at Yale New Haven Health System in the adult program, we have about like 260 active patients. So we may have had a point of contact with over 300, but ones that we care for regularly, it's about 260. And it's about the same on the pediatric side. So I actually see both pediatric and adult patients. So we cover both of those spaces. And the bulk of our patients in the state of Connecticut are here. We have great colleagues like Marie and Miriam up at UConn, who also cares for sickle cell patients.
And I see Reverend Perry's pensive face. So I know that means he has a question that kind of come in. But I want to just, when you mention pediatrics, some people they may not even believe or understand that young folks. So tell us about, typically you think of sickle cell as the adult kind of phenomenon. But when you mention pediatrics, I mean, this is just something that people need to know about.
Yes. Well, sickle cell disease is an inherited disorder. That means that people are born with it. It's not something that you catch or you come across. And so actually, in the kind of like late 70s, there were really two peaks of death. There was a big peak in infancy, ages like 1 to 4, our babies were dying. And then it started to rise in young adulthood. But because of multi-center trials, we found that if we identify sickle cell babies or babies with sickle cell early, we start them on prophylactic penicillin or antibiotics to cover infection. Really, we keep our children alive until adulthood. But that peak of morbidity really starts and continues to rise around adolescence and young adulthood, which is why that's where my research focuses, because I'm like, we got to do something about this part now. I know that even though we've been able to do well for our babies and we will continue to do well for our children, it's important for us because the life expectancy is still only about 43 years of age. That is strikingly and unacceptably low. So, it's important for us now to really add to our focus and making sure our young adults are safe. So, so your sickle cell is inherited, so you're born with it. And in the United States, African-American pediatrician, Charles Whitten from Detroit, which is where I'm from, we have leveraged the power of the newborn screen. So now if a child is born in a hospital, they do a little heel prick or finger prick, get a little drop of blood, and it tests for many genetic disorders, one of those being sickle cell. And it allows us to wrap our kids in subspecialty care early, give them what they need to survive into young adulthood. So.
Excellent. And Reverend Perry, just before I bring you in, I guess it just dawns on me, Dr. Calhoun, that although we can assume that people know what sickle cell disease is, but I've done the show for 7 years and I'm still finding people that are just discovering me and just discovering even what sickle cell means. So share with us a little bit, just what is this sickle cell disease and why are African Americans kind of predisposed to carry this particular gene?
So if any of my patients are listening, they're probably gonna roll their eyes because I use the same description all the time. Okay, and it always has to do with food. So a normal red blood cell, which is in our blood, we have three kinds of cells. We have our white blood cells; those help us fight infection. We have our red blood cells that carry oxygen to our body, give us energy, make sure all of our tissues, organs, we are alive and thriving. Then we have our platelets, which nobody ever talks about, but basically that's the cell that makes sure that we don't go gushing blood if we get a paper cut or a nosebleed. And sickle cell affects the red blood cell. So a normal red blood cell kind of looks like a jelly donut. The sciencey name is a biconcave disc, but it's round, kind of flat, it's very squishy, malleable. When you have sickle cell disease, instead of your red blood cells looking like a jelly donut, they look like a banana or a crescent or a sickle, which is what people used to use to harvest crops. And in addition to being shaped differently, they're also very rigid, they're very sticky, and they're very sharp. So if you think about your blood vessels as pipes, right? You got your jelly donut cells kind of swimming through in your plasma, taking oxygen to every part of your body where it needs to go, keeping them healthy. If you replace greater than 50% of those, which is in many of our patients, with those rigid, brittle, sticky, misshapen cells, they're maybe going through the sides of the pipe, scratching it up, causing inflammation, or sticking to the sides of the pipe, sticking to one another, and preventing blood from going through. And so when we think about all of the clinical manifestations or complications of sickle cell disease, it's that lack of oxygen, that inflammation that really causes many of the complications we see, including the most common presenting, which is pain. Yeah, and I think, the importance of platforms like your show and having an awareness month is that, like you said, a lot of people in our community are affected by sickle cell, but not many people know what it is, and it's a silent disorder. And so people can be going through those complications and really, they look fine from the outside, but are really, really, working to live a healthy life. And you say, well, why do we have sickle cell disease? So it's actually an evolutionary trait, right? I'm telling you that, hey, it makes our red blood cells look different. In any country where malaria, which is a parasite that lives inside of the red blood cell, is prevalent, our body said, you can't live in my red blood cell if it looks different. So we developed it to protect us from malaria. So that's many of the countries in West Africa, Sub-Saharan Africa, India, some Mediterranean nations. And you're like, hey, but we in the United States. So when people usually ask me this, I usually pause, but I feel this is a safe and candid space. How do we get sickle cell in the US? Slavery, y'all. Transatlantic slave trade, okay? That's how we got over here. Okay?
Economics and geopolitics.
Okay, you know what I'm saying? So anywhere, it is a disease of Africans on the diaspora, whether that's the US, whether that's our island nations. That is why sickle cell continues to remain prevalent.
Excellent, excellent. Reverend Perry, can I share? It's good to see you. And we've been doing the shows for a few years now, and just amazed me the commitment of you and Reverend Clayton and the cultural ambassadors to the ministry. I mean, you guys are ministers. I mean, you're proud of that every Sunday. You kind of remind people also during the week that you carry that role, but also 24/7, 365, you're concerned about people's life. You guys have done a ton of funerals. If I could just make a personal comment, you've done a ton of funerals, so you see what's cooking in terms of this life and death nexus. So why are you here today, Reverend Perry?
I'm here today to be with Cece.
Me too, but I believe she has. But we're members of the fan club. That's clear, and we're going to renew our annual dues. But in addition to that,
and see, I think that you touched on earlier the dark side of the inequity that somehow is prevalent in the field of medicine and research with regards to Black and African Americans, minorities. I looked at the article with you and Krishnamurti, Cece, and it just brought again out to me, there is a dark side. I'm so glad that you mentioned the African part, because people think in terms of religion that when a person has something, God gave it to them, and so it's a curse, or, you know, and people look at it, but they don't understand the genesis, the evolutionary genesis that you broke down. Africans in the rice fields, they had to be in water's there all day, and then the mosquitoes come, and then, you know, the malaria. But it's good to know that, because now we shed some light on that. But the darker side is what you mentioned in the article, how cystic fibrosis, for example, gets so much money for research. And when it comes to sickle cell and diseases that may affect African Americans, the funding is not the same. One of the other things that you said in the article, two things. One, you said there was, in 2017, there were 3 new medications. And then the other thing about the gene therapy. And one last thing, and I want you to talk about the gene therapy, because that's really interesting. I know Howard University just gave $1 million or more grant to do gene therapy with African Americans, so that's going to be powerful. I also know that in 1996, New York required that babies who were born African Americans would be tested for sickle cell. I think, is that a national thing now? Is it done in Connecticut?
Yeah, so that's the newborn screen I was mentioning. So I think really, you know, I don't want to get this particular fact wrong. I'm going to just be broad. It was in the 80s that that we started nationally. I think we have all states in the newborn screen that tests for many things, but one of them is every baby. Like, even if, you know, because we're a very heterogeneous population, you know, so you may not look, and I'm throwing up the quotes, look Black or whatever, but, you know, you can have trait or have in fact have sickle cell disease. So yeah, we test everybody born. So.
Excellent. Reverend Clayton, it's good to see you this morning. And again, I just want to give, you guys have to bear with me. I just feel like I just want to give out some props and roses to everyone. I hope folks understand that Reverend Clayton and Reverend Perry work on Sundays, and Mondays are typically the day off for many ministers, and legitimately, because they're working all the time. So for you guys to be so consistent and diligent on a Monday morning, I just want to salute you as well. But Reverend Clayton, good morning. Any thoughts on what you've heard thus far, or questions for Dr. Calhoun?
Yes, sir. Cece, you made it so clear that a part of your talk this morning, that the sickle cell patient, they look good. They go through life, they work, they handle their business, and it almost looks as though all of a sudden when they have this issue with sickle cell, their body is wrapped with pain, and people sometimes don't even believe these people. And so for you to bring it up so clearly as to why, the internal thing that goes on with the blood is so important. So I appreciated that comment so greatly. Thank you so much.
Yes, let me just say this also. Reverend Clayton and I were at an institute for the National Association of Black Nurses. And while we were there, one of the mothers came up to us and said that her daughter was going to a hospital in Yale. It may have been the sickle cell clinic. And the doctor in charge, when she went in, would not give her drugs because he said that she was only going there to get drugs. And this is part of the dark side that I'm talking about. Mm-hmm. And so, you know, it's like the stigma that even medical doctors who ought to know better would associate a sickle cell patient as a drug addict. And these persons were, you know, and can be in tremendous pain. And this is what the mother said. She said, my daughter was in extreme pain. And this is the kind of stigmatized treatment that she received at Yale. Of course, we reported this to Tisha, who also took it up to some other people to investigate this. And, but I mean, there is that dark side. And not only the stigma of being maybe a drug addict or being in pain, is people just don't understand the depth of pain, not only physical, but mental as well, that these people have to carry. And so maybe, because we were trying to get, on your show, Tom, we were trying to get a sickle cell person to come on and share with us their experience. It's very hard to find one, because the stigma, you know, is part of what keeps people from wanting to share their story, because they're going to be judged one way or another, either as a person who you should pity or a person who is got a problem, and opiates is one of the solutions.
Doc, even in my congregation, I had a member that was a sickle cell patient, and the difficulty he was having is the same as the mother shared with us at that convention. And the trouble he was having was, like most meds, you have a certain amount of time before you can get the next prescription filled. And when you're in pain, it's very difficult for these people to say, well, I can't take the pill because I'm in pain, and the insurance companies and the pharmacists need to change the way they prescribe these medications for these people. I don't know if Cece could address that some way, but his struggles was when he was in pain, he couldn't get meds. And when he would go to the pharmacist or call his doctor, there was always a delay. So,
can I jump in? Do you mind?
yes, you can.
Okay, so I think you both have covered a few. I had to write down some key points here because to make sure I get to them. But there are a couple things. One of the reasons I feel most fortunate to work with sickle cell patients is because I feel that the strides we make in this community will affect our whole community. Because the issues that you all are talking about stigma, about access to care, about shared decision-making and how you're treated by physicians and how you engage with them, it's a lot of Black people that have those same problems. And I think our awareness has increased, and, thanks to champions like you all, we're able to move science forward as well. But how we treat sickle cell patients is mostly how we treat, like, how Black people get treated. Even me as a doctor, if I don't lead with that, and I don't sometimes, I'll be treated differently, and it's completely unacceptable. So when it comes specifically to the patients and populations I treat, so for me, technically, we talk about this term of intersectionality, and it manifests in my own work because I'm a Black woman, I care for Black patients, I'm also in this healthcare system. And so I can see the re-education of my colleagues that needs to happen about sickle cell disease, about how patients experience pain, about appropriate treatment of pain. There are guidelines from the National Institute of Health, National Heart, Lung, Blood Institute that say if somebody comes into the emergency department with sickle cell, you give them IV pain medication ASAP. These are evidence-based guidelines, okay? But we have to put these into practice. We have to educate, I have to educate my colleagues. And then spaces like this, where we're also educating our community, right? So we let go of that stigma too, where we educate everybody about what sickle cell disease is. That's one of the ways we advocate for our patients so that they don't have to be suffering from sickle cell, having pain, having other complications, and be the people responsible for that education piece. I think that is one big thing. And then one of the other things I think is this whole process and and like health outcomes research, we call it shared decision making, but it's basically like, talking with your treating physician, coming to a consensus together, especially when there's not a right or wrong answer. Because when I talk to patients about hydroxyurea, which for decades is the only disease modifying drug that we have for sickle cell disease, I can tell them why it works. I can give them statistics about how it'll make their life last longer. Literally, I have data for that. But if they don't want to do it, then I can prescribe everything I want. I go take it at home, right? And so I use that example because it's a little bit less stigmatized than pain meds, but it's an example of like how if you are a healthcare provider, you have to really understand the whole person, not just like a patient with a disease, because that's how you actually get to getting the best possible outcome, the thriving that we were talking about earlier. That's how you get to it. And I think with sickle cells, particularly with pain, like we talked about, is silent. There are no, and I have to write this in like actual medical records often, there are no objective signs of pain. You have to believe the patient when they tell you what's going on, And then I think the other piece is people remember the worst rather than the best They'll take one person who maybe, is not their best and apply that to a whole population, you know?
Wow.
And that's, and like it compromises our ability as healthcare providers to give good care. And so working on that unconscious bias is something that we're working to do. I'm working with actually a couple of colleagues from Yale who were here before, just holding our own colleagues accountable in that space. And look, so I think I hit all my things, but I the work we do with sickle cell patients, it applies to, that's what I wanted to say. You made a comment about pain, and there's actually literature that shows that there's a study done amongst healthcare providers that they thought that Black people experience pain differently. This is published in a medical journal, y'all, in the 2000s, And so, I think it means it's another example that we have a lot of work to do. But, we are a community of survivors, of resilient people, of innovators. And so that's kind of like my hope in terms of why I know we're going to do better, because it's not just sickle cell warriors who are fighting this battle every day, but it's the people in this environment right now we are committed. We're standing with people who have sickle cell. We are holding people accountable in every space we're in, and we're going to move the field forward.
Dr. Cece, I think that it's systemic, and because I was reading Harry Washington's book on medical apartheid, and one of the experiments that they did during the South, the doctors all agreed that Black people could handle pain better than anybody else, and so they would not give, like the women, they wouldn't give them any anesthetic when they were working on them or treating them. So it's kind of crazy. And how do we change that? How do we change the new students, medical students, into believing, that, hey, it's a new day? And unless we get more people like you and more people like us involved, it's not going to happen.
Yeah, you hit on a lot. I mean, it's absolutely systemic. We know that kind of our societal discrimination, racism, those injustices, they inform our policies, right? And our policies really inform our environments, like what we have access to. And those environments inform our risk factors, right? They inform our diagnosis and treatment and how we access care. So, I had the chance to talk to some Yale School of Public Health students a while ago, and they're like, okay, how do I get involved in health equity? And I said, wherever you are, when you're standing up for the right thing, you will be impacting it, because it's a long pipeline, like you said, that starts even before medical school. How our kids get access to different education, what they aspire to be, what they see, all of those things eventually have end games, and one of them is better healthcare for sickle cell patients. But it is all intimately connected.
Dr. Calhoun, I was really fascinated to kind of listen to everyone's discussion and input and real wisdom. But I was curious, Dr. Calhoun, if you would share a little bit about maybe weaving together some of the new treatment options in conjunction with your research as well, because although there's a dark side, I kind of love the light and brightness that you're bringing to the darkness. So maybe share with us a little bit about your research and new treatment options.
Listen, I'm no Reverend Clayton or Perry. I'm not mobilizing and inspiring the folks with biblical text, but I do know a little bit of science, just a little bit, and I'm trying to learn more. So, really up until a few years ago, we kind of had only one thing that actually treated sickle cell versus the complications, and that's hydroxyurea, which works by telling your bone marrow, which is where we make all the cells in our blood, to make fat, juicy, big fat jelly donut cells rather than sickle cells. But over the past 5 years, we got Endari, which is a amino acid L-glutamine that works to decrease pain. Then we got Oxbryta or Voxelotor, which is a drug that increases hemoglobin, and in that way really works to modify disease, right? Because most patients with sickle cell are anemic. Then we got Adecbeo or crizanlizumab, which is an infusion treatment that we use to prevent pain. And we've had bone marrow transplant, which is the only cure for sickle cell disease for quite some time. But there are many scholars working to make that safer. But then we also introduced gene therapy, which is where we can take our own, all right, I'm gonna use the terms, hematopoietic stem cells. So this is not a stem cell that's you're gonna put in a petri dish and grow a person. It's not happening like that. It is the parent cell of all those cells in our blood, okay? Those are in our bone marrow. And with gene therapy, we can take someone's own parent blood cells out and then modify them and fix the genetic error or genetic change, that causes sickle cell using different techniques outside of the body. Yeah, science, right? It's amazing. And then we give it back to that person, allow those corrected cells to replicate, and thus eliminating sickle cell disease in a person. Now, I want y'all to know that is a simplification. Okay, I made that there are lots of nuances and steps and safety that goes into that. And as we start to open trials here at Yale, Dr. Krishnamurti, who is our pediatrician in chief of our PT-MOC section, he is really, really leading that here locally for us so we can give that access to our patients with sickle cell here. But as we start to learn more about that process, we make it more safe. We get to go into detail. We figure out who's the best candidate for these kind of procedures like transplant or gene therapy. How do we do that? And a big part, I never want to lose this, is not just the medical team, but the community, as people are going through these very, very nuanced, very complicated, very challenging medical experiences and procedures. We need people who are not in the healthcare system, right? That sometimes patients often have to push against when we think about trauma-informed care to support and lift them up. It's that community piece. So those are some of the things. And then for me, what my work focuses on is, okay, we have all these new innovations. We got these evidence-based guidelines. How do I work with the people to get them to them? So I do health outcomes research, but particularly in adolescents and young adults, because I shared a little bit early in the program, that's when the mortality starts to rise, to try to understand how do we support them as they go from that peds to adult care? How do we engage them in their care? How do we optimize their health literacy to make sure they understand what's going on with their bodies? How do we support the parents and family and letting their little one who they love, have worried about, are afraid for sometimes, take on their own care and management? How do we introduce these new therapies? How do we leverage all that we have in the healthcare system to make sure they have better outcomes? So that's new therapies, gene therapy, which I know Reverend Curry wants to talk about too. And then also, the research I do is really putting that into practice.
I think that your research, when you came to us, you were researching with adolescents, and we said, wow. And so the topic that Tom and we're trying to move on to is how does the community somehow support the research that's so necessary? Like you said, how do you convince somebody that maybe they would be a good candidate for this? And what kind of ways can the community back that up? I mean, if you said the eradication of sickle cell is somehow in our hands, that we really need to push toward this as a goal. And so we have all of these gene research projects going on. How could we help recruit for those? How can we help people to understand the importance, And again, I mean, like you said, there's so many levels. Is it for young people, or the older people? Is it for newborns? This gene therapy is radical. And
it's so exciting too.
Yeah, it is. It's amazing. It's amazing. I was reading this book on the Emperor of All Maladies. And one of the things they said at the end of the book about cancer is that they could take your gene, that your genes didn't see the cancer cells in the body, so they didn't your autoimmune system would not attack them. So they could take a gene out of your body, re-engineer it, so when it goes back in the body, it will help your antibodies discover the cancer cells. Now, to me, that was like, wow, you know?
Yeah, that's CAR T therapy, like using our own immunotherapy for many different conditions where we say, how do we leverage our body's own immune system to protect us against these abnormal, unregulated cells, which is what cancer really is.
And
I actually want to pose a question back to you. I mean, the work that you all did with helping us move forward trials in COVID in New Haven, was one of the reasons that I don't care what my projects are. We coming to talk to the YCCI community ambassador. We need to get advice, okay? And I would encourage that for any of my colleagues to do research in this community, because there are going to be gaps that we see as scientists that you all will see, not just from practical experience, but from lived knowledge. And so when you tell me, Reverend Clayton, how do I get more community members engaged in science? What worked for you all? How do I really do that? Tell me what to do.
Wow, that's a loaded question. It's loaded. That's good. That is really.
Dr. Calhoun, let me filibuster and give them some time to think about your answer
Okay.
to your question. What kind of candidates are you looking for now to help you with your research? What someone that's early stage or has been dealing with sickle cell for a while or has a trait or?
Yeah, so for me, and this is just the research I do, like me as an individual, but one of my goals as medical director is to support the development of new and innovative research for sickle cell here at Yale. And I think that is a goal of, I feel comfortable saying, of our cancer center leadership as well. And so while I'm looking at adolescents and young adults, we have some young people coming down the pipeline who want to look at neurocognition in adults, right? And understand what that looks like in adult patients with sickle cell who can have strokes. And so the inclusion criteria and then there's great work going on already, like I talked about in our pediatric section with sickle cell, and even some people looking at the immune system in sickle cell here. So I think that, there is a small but yet growing amount of research about sickle cell here at Yale that's really, really going to grow. For me, I think that there is a myriad of ways in which the community can be involved. I'm always inspired by Yale Center for Clinical Investigation and the young ambassadors, these like high schoolers who are learning about clinical research. I got the chance to talk to these young students and they were talking about creative ways for recruitment. And I was like, are any of you guys available? So I think engaging even our person with or without sickle cell interested in research, giving them that exposure, they have great ideas. So if those young people are like, I want to learn more and do more, they can help us even in learning study design and what's appropriate. And so then when we think about our community leadership, just the knowledge and awareness, obviously, about what sickle cell disease is, but also, hey, Yale is doing a study on this. They're actively recruiting. Here's the info. But also, I think assuaging and talking to people that trust you all about the importance of trial participation or research participation, because as you alluded to, we have been experimented on as a people in the past. And when a person with sickle cell interacts with the healthcare system, because of all that stigma, there's not necessarily an inclination to trust the person unless you know them, And so how do we kind of like build that trust? So it's a knowledge exchange. I'm very intentional about, it's not just getting a community part. There's stuff I know and stuff and there's a big gap that I don't know and I need you to teach me. So I think creating a space for those things as well. And then when it comes down to just frank study recruitment, asking the questions you need to ask, but not being afraid to enroll as you see things coming around, and not just only being afraid to enroll, but sticking with it and sticking it through so that we can have all of our retention to the end.
Can I go back to that question you asked earlier?
Absolutely. We gave you the time to think about it. So absolutely.
It goes further than just clinical research. one example that I will give is that there was a young couple that was having some trouble with their marriage. And the problem was that the young lady was saying that he seems to not want to be close to her. He didn't want to be bothered. He'd come home and go to sleep. Comes home from work and goes to sleep. And so I had a conversation with him, a conversation with her. And these two people, they love each other, but they're the problem here. And the problem was this gentleman gets up at 3:30 in the morning to go to work. And then by the time he gets home at 6 o'clock, all he feels like doing is getting his dinner and going to sleep. And so my answer was very simple. Look, the man is tired. So you got to figure something else out here in terms of, pick a day on the weekend so you guys could go somewhere and things should be better. So that's a minor thing. But those are the same people that will come to us and say, my son has sickle cell, or my daughter has asthma. It goes back to what you said earlier. It's the trust factor. We're the same people in the community, the same pastor that's baptizing their babies. We're the same people that are marrying their young adults. We're the same people that are burying their loved ones. So when we have been trained some 200 hours, is that correct, Dr. Perry, in clinical research, and when we're not doctors, but we have knowledge of certain things, and when we share these with our parishioners and with members of the community, that oftentimes they will listen. And when we listen to people, that is another key. Listening to people. In terms of sickle cell, if the medical profession would listen to the patients, because they don't look like they're sick, they don't look like they're in pain, they don't look like they're going to die, but they do. And so Dr. Perry and myself and the ambassadors, listening is one major piece. They trust us, another piece, and having knowledge of various diseases, another piece.
Yeah,
about nine or 10 minutes. So let's kind of anything that's on people's minds in spirit. Let's share.
I think that Reverend Clayton is correct in the sense that it has to be collaborative. Mm-hmm. Like it can't be just the community, and it just can't be the researchers. It has to be this relationship together and understood in a way as to have this commonality with regards to people who might be participants in the study. And it can't be one-sided. It can't be just what the researchers say, and it definitely can't be just what the community. It has to be this working together. So there are a number of phases here, Cece. One is that collaboration. Two is how do we change policy in order to get more funding for such a serious malady within our community. I mean, what can we do? I was reading an article about ringing the bell. I said, well, I didn't see the bell in my area, but I'd like to give. But we got to get more people. And it's like the wagon that makes the most noise gets the most attention. We've got to put, and so all of those factors it should go into a succinct plan, not just one thing. We should do it. How do we change public policy? How do we do recruitment? How do we make it simple and understandable? And how do we get our communities to trust the research and the researchers so that we can really better healthcare for all? Because like you say, if we do it here, we can do it and for prostate cancer, breast cancer. I mean, how do we do this? And that's what we've been working on. And I just think that sometimes there's a hesitancy on the part of researchers to come to the community, and there's a hesitancy of community people to trust researchers, like you said, because, medicine in America has been built on Black people, and they're testing and using and, all that kind of stuff that makes us suspect of anyone who seeks to want to do something good here.
You brought up a really good point about leveraging policy for funding, which is one of the things we all often talk about when it comes to like research funding and comparing to other rare diseases like CF. Um, and recently, there was a bill that was passed, the Sickle Cell Disease Treatment Centers Act. Cory Booker was like a sponsor of it, and Chris Van Hollen, who's in Maryland, I think, and a couple of U.S. representatives, Barbara Lee and Danny Davis, to advocate for over 500 million in grants annually to try to really reach at this disparity. So, like, it's a really fertile time. It's like finally, I'm like, yes, like people are finally paying attention. But it's just the beginning, y'all. It's really just the beginning. One of the other things that I was thinking about as I was listening was, how do we support? All right, so we as people, just in general, we're humans. We're complex. We have layers, and sometimes one of the things I've been really trying to think through and don't have an answer for yet. So maybe we'll talk about it on the next iteration of the show. But it's how we support patients who really feel like the medical system isn't listening. And I would love, like after I met with Leonard Jihad, there's like hospital-based gun violence intervention where a community member comes in and is able to, while the person is here, in this space, be with them. I want to do something like that for our people with sickle cell. Like when they're here, they're in pain. Can there be a community advocate to come in, or how do we support them? And I don't have the great answers for that, but I know I have some great minds I'm sitting here with, so why have the space? And if there is anyone listening who has like any, formative ideas about how we really support our patients when they come in and they're going through these pain crises and are kind of like feel unheard, how do we as a team, as a program, fix that? And I don't think it's going to be just providers. I think it has to be people from the community, like Reverend Clayton was saying, that trusted relationship.
I definitely have some thoughts in that regard, and we have about 6 more minutes. I just wanted to say that I want to publicly commit to Dr. Calhoun and Reverend Clayton and Reverend Perry that I will find by tomorrow 3 people that are dealing with sickle cell that are be willing to tell their story.
Yeah.
So by tomorrow, I'm publicly challenging myself. You'll hear from me with 3 people that'll do it. But we have about 5 more minutes. So let's kind of continue the sharing. Any thoughts that you might have, Dr. Calhoun? Share with people also that Hispanics are subject. You mentioned the diaspora and the Caribbean islands. So share this. Just not exclusively Black folks that are kind of dealing with with this trauma and dilemma.
Yeah. Any place where Black people got peppered across the world during, transatlantic slave trade, and not just like normal migration, sickle cell can be prevalent. So, whether I have patients from Puerto Rico, I mean, pretty much most island nations,
Indeed,
because that's where, we as Africans on the diaspora were taken slavery. So, and then also,
I'm sorry, go ahead.
There's also like in the Mediterranean nations can be a large population as well. So some people, just because you don't look Black doesn't mean that you can't have sickle cell or trait, which is important, especially when you're thinking about having a baby.
Indeed. So go ahead.
I have one
Reverend
question.
Perry.
So if my daughter had sickle cell, I'm in the New Haven community, and she has a pediatrician. Would that pediatrician be the person to treat her, or would I go to your center, to the sickle cell center with that child? I mean, how does that work?
Yeah. So there are not enough hematologists to care for sickle cell patients. That's the bottom line. And so we have to think about training up our workforce, like we talked about, but also new and innovative models to make sure our patients get the best care. In major urban centers and cities, there are specialized sickle cell programs. And if that is available to your daughter, then she should come see us for sure. But there's some rural areas where that's not available. And so the American Society of Hematology is working to say, how do we partner with primary care physicians to give them the knowledge that they need to give the best quality care. There's some things that require the care of a subspecialist. if someone goes through a major complication of sickle cell disease, I'm not just talking about pain. I'm talking about stroke. I'm talking about retinopathy. I'm talking about kidney issues. They need to see a subspecialist. If it's, but primary care doctors can prescribe hydroxyurea safely and should always have access to their colleagues, whether now we can leverage the power of telehealth, right? That's one small good thing we took away from COVID. To make sure even our primary care doctors feel equipped. But in most major cities, there are sickle cell centers that patients can come and get that comprehensive care.
I was watching this program on heart disease with Eric Velasquez and his team. And what they did was they had a presenter from Africa or Jamaica. And he was saying that how he partnered with Yale with their doctors so that when they had a person, all of these doctors could share in, the care, since they didn't have the quality of medicine and the resources that the West had. This is how they were attacking the problem. And I think this might be a way for us, because we're looking at a kiosk for the ambassadors in the community. And if we could do something like that, it might be awesome.
That would be great.
Two more minutes, everyone. And I want to give Dr. Calhoun the last word. So let's share. Reverend Clayton, any thoughts? I want to give Reverend Dr. Calhoun, Reverend Dr. Senior Pastor Calhoun. We're going to anoint you and bless you in telehealth, teleministry.
Okay. Listen,
at least elder. At least you can be an elder. At least something. So get on that hierarchy somehow.
No, deaconess.
Deaconess, yeah, deacon, right. Reverend Clayton.
I just want to take a moment to thank for this platform, and I thank Dr. Cece Calhoun for being so candid and so open with her comments today. It has truly helped me, and I'm sure it has helped our listeners. Much peace to you.
Dr. Calhoun, I'll give you the last word. Medical Dr. Calhoun, and then other doctors to be to be determined.
I echo those sentiments. I thank you so much for this opportunity. I think when I think about my patients, one of the things they feel most is misunderstood or not understood. And so the space to not just provide education, but for people to see like, hey, y'all, we are a whole community. We care, we love you. We want to do better, not just the physician, but your spiritual leaders, your community leaders. It's so important. And so I am happy to be back. I can't wait to join again next year. I'm signing up right now. And I hope that we talk
next week. Next week.
But I want to collaborate. I want our patient. I want you to find those 3 people with sickle cell, and we want to hear from them.
Indeed.
So I thank you. I just thank you so much.
Indeed. Harry plays the music, so I'm going to push your envelope a little bit, Dr. Calhoun, and you've already kind of indicated this. Advice that the families and individuals in terms of family care and treatment. You kind of alluded to this, but say a little bit more about the prayers and the wishes and the directives that you might want to share with families and individuals that are dealing with this.
Don't lose hope. Sickle cell patients and people with sickle cell are called warriors for a reason. The science, we're not there yet, but we're going to get there. The community is here for you. And I want to give you the best care I possibly can. So tell us what's going right. Tell us what's going wrong so that we can be the best for you, because you're not by yourself. We go far together.
Excellent. Thank you. Thank you so much. Thank you, everyone. Thank you, Harry.
Thank you, Tom. Thank you, everyone.
Thank you.
So great to see y'all.
As I got another rhyme, another rhythm for y'all to listen. I'm never quitting on my mission. I'ma roll with what I'm giving. Got some ambition, this new edition, filling positions. Looking at the void in myself and feeling what's missing. Better watch the way you going. Better go in the right direction. In the moment you stressing, but you gon' be counting blessings. And I know that for certain. Keep on working, open curtains. Haters swerving, cause they ain't ready for your final version. I'm never gonna give up. Fall down, I just gotta get up, yeah. Cause this is my road. Let's get